This lecture covers brain tumors. What you can see in this slide here is a tumor that was removed where you can find teeth embedded in the tumor tissue. You'll find different types of either undifferentiated or redifferentiated cells within tumors, depending on the degree to which the tissue has been mutated. In the first part of this lecture, we're going to cover tumorigenesis and some of the different types of primary brain tumors. And then we'll go through the prognosis, or kind of the outcomes that we should expect with brain tumors. In general, tumors that are arising within the brain tissue, that arise from neural cells, tend to have very poor prognosis, whereas tumors that arise from non-neural cells, such as the meninges, tend to have much better prognosis. You can classify tumors based on the type of cell that makes them up, where they originate from. For example, are they primary brain tumors or are they secondary? If they're secondary, that means that they've come in from other areas of the body, they've metastasized. That automatically places them in a higher category of aggressiveness because they're able to break off of their mass and move into new tissues. Now, normally cells control the cell cycle very tightly. There are genes that are devoted to progressing the cell cycle, and there are genes that are dedicated to preventing progression through the cell cycle. Now, neurons don't go through the cell cycle. They've removed themselves from the reproductive game. They've differentiated into these elaborate morphologies. And their job is to just stay where they are and communicate, receive input in their dendrites, and project output along their axon. Other cells continue to go through the cell cycle. Any cell that goes through the cell cycle has the risk of creating a cancer cell. Neurons don't. If they're pushed into the cell cycle, they die. Other cells can actually complete the cell cycle. The genes that progress through the cell cycle are called proto-oncogenes. In other words, before cancer genes. That's what that means. So they're not yet genes that cause cancer, but when they mutate, they will create oncogenes. Some examples of cell cycle promoting genes would be the cyclins and cyclin-dependent kinases that you undoubtedly learned about in your general biology classes. These are created in cycles. That's why they're called cyclins. And the cyclin-dependent kinases are kinases that are only active when cyclins have been created. So at different phases of the cell cycle, different kinases are active and they do different things, such as promote cell growth, or promote the replication of the DNA, or promote splitting the cell in half. Then there are tumor suppressor genes, which are going to act as the brake. These prevent movement through the cell cycle until some important checkpoint has been met. Now, for example, did we attach all of our chromosomes to the mitotic spindle so that whenever we try to pull them apart, we separate our genome cleanly in half? Or did we fail to copy our DNA completely because we've accumulated mutations, we have breaks in the DNA? If we can't replicate it all, there's a good reason for it. And when tumor suppressor genes prevent cell cycle progression for long enough, invariably they lead to cell death. And that's an important part of their job. So the example here would be if we have DNA damage, which happens. Mutations happen. The protein that picks that up is called P53. That's because it's a protein, that's the P, and it's 53 kilodaltons in mass. P53. Not a very descriptive name, but that's what it means. When we have DNA damage, this causes an increase in the level of P53. P53 then stimulates P21, that's a protein that's 21 kilodaltons large. That inhibits the activity of our cyclin and cyclin-dependent kinases so we don't progress through the cell cycle. If we have prolonged upregulation of P53 and P21, the cell kills itself, so it undergoes apoptosis. Mutations in P53 are the most common mutation that you find in cancers. So if we're unable to detect DNA damage, then those mutations just get passed on to the next generation, and they get amplified and passed on to the next generation. So here we can see a few different cyclins through different phases of the cell cycle. G1 would be the first growth. S phase is where we replicate our DNA. You'll notice that cyclins come on and come off, so they cycle in different phases of our cell cycle here. That second growth and the M phase, where we actually undergo mitosis and split in half, we're going to see a different makeup of cyclins and cyclin-dependent kinases. Again, when we have DNA damage, P53 detects it. The two things that it will do is prevent progression through the cell cycle, and if we can't fix the problem, if it's not a minor damage to the DNA, if it's unfixable, then the cell goes through apoptosis. The whole purpose is to prevent the passing down of mutations, because it's mutations that cause cancer. When we have a gain-of-function mutation, for example, in a proto-oncogene, so now our cyclins are cycling much faster and in an unregulated manner, and we're progressing through the cell cycle more rapidly, you run the risk of developing a cancer, of reproducing in an unregulated manner. That's what a cancer is. Cells that are reproducing abnormally. And you can do that whenever you have too much gas. So whenever those proto-oncogenes are mutated and you're progressing through the cell cycle more rapidly, or by relieving the brake. So a loss-of-function mutation, for example, in P53. That's common. When you lose P53, you lose the brake. So DNA damage moves on through, and we create a whole bunch of mutated cells. And the degree to which those cells are mutated is going to determine kind of how they look. Their nuclei are going to get much larger. They might have multiple nuclei as a result. The cells are going to essentially de-differentiate and become anaplastic. The tumors that we talk about, you can call them benign or malignant, and that kind of depends on their growth rate and how invasive they are. So a benign tumor is still a tumor. We still have cells reproducing in an inappropriate manner, but it's not as aggressive as a malignant tumor. That's when we call something a true cancer, because in a malignant tumor, cells are reproducing rapidly, and they're able to leave that cell mass and move to other parts of the body. So a benign tumor might sound like it's not a problem, and it isn't at that point, but it can continue to grow and become a problem, or it can continue to mutate and become malignant. So a benign tumor is only benign until it's not. Now with primary brain tumors, you can see that the prevalence varies across age. That's fairly clear here. The older you are, the more likely you are to have really any kind of cancer. So when you see clinical signs in much older patients, the general rule of thumb is to assume it's cancer until proven otherwise, or if there's a good reason to think it's something else. Because the biggest risk factor for cancer would be age. The older you get, the more time you've had to accumulate mutations, the more likely you are to have improper cell cycle progression. Of course, if you've been exposed to ionizing radiation, something like a bunch of X-rays, this can damage DNA. And of course, DNA damage and mutations is what causes cancer. And a family history. So if you have heritable mutations in, let's say, P53. So if your family's P53 doesn't work quite as well as other folks, you might have an elevated risk of developing cancer. The symptoms of brain tumors would be similar to what we saw last lecture. So there's going to be an elevation in intracranial pressure. Because again, we only have finite space within the skull. So if you have a tumor forming, occupying space, reproducing, growing, it's going to increase the overall volume inside that skull. And by increasing the volume, what you're going to do is start to increase pressure within the cranium. So headaches can occur. Classically, these are described as being worse in the morning and getting better throughout the day, although this is probably the minority of cases. There can also be nausea and vomiting because of abnormalities in vestibular function, so compression of the brainstem, for example. And it's not uncommon to see visual disturbances. So here in this image, we can see a sixth nerve palsy or improper function of the abducens nerve. So when looking to the right there, you can see that his right eye fails to abduct. After removal of the tumor, shown on the bottom left of the panel, you can see that his eyes are restored. Here's another example of sixth nerve palsy here. So pressure on the cranial nerves can impair their function. We'll get into why in just a little bit. Another sign of intracranial pressure elevations would be actually pressure that you can see on the retina. So jutting through here, we have our optic nerve there connected to the eyeballs out here. And as we're increasing pressure back here within the skull, that's going to push on the optic nerve there and actually cause the optic disc to bulge out. And you can see that happening as you go from 0, 1, 2, 3, 4, and 5. You can see that optic disc start bulging out. And that's because of the amount of pressure that's back there behind the optic disc. So with an increase in intracranial pressure, it's going to push out the optic disc. Of course, depending on where the tumor is, you're going to have a variety of signs. It can affect your cognitive function, it can affect your ability to move, your ability to feel, whether that's somatosensory or emotional feelings. Again, it's all about the location. If it targets the cerebellum, you're going to see ataxia. If it targets the brainstem, you're more likely to see impairment in vital function. Seizures are not uncommon, especially in the later stages, and we'll go over why that occurs. But in part, it's from a little bit of gentle pressure, but also disruption in proper buffering of extracellular potassium. The diagnosis of brain tumors is going to rely on imaging. Imaging is a big factor here for how we make this diagnosis. MRI is a great way of imaging brain tumors, especially because you're not exposing the patient to x-rays like you do with a CT. But a CT scan can be useful for detecting larger tumors or to see gross herniation of the brain. So if there's massive increases in intracranial pressure, we can still get herniation, just like last lecture, and we can see that here in this image. Right there we can see kind of herniation there of the caudate over, so we're squashing the lateral ventricles there. You can use contrast agents to help kind of light up the tumors there, so this T1 weighted MRI is a lot clearer whenever we add a little gadolinium. So this is a contrast agent that's going to enter areas where you have kind of a leakier blood-brain barrier, which you have with tumors. Another type of imaging that can be helpful for distinguishing when tumors have been properly dealt with, in other words killed off, would be FDG PET. FDG is fluorodeoxyglucose. So this is glucose, but it's been made essentially radioactive, so we can pick it up by positron emission tomography, or PET. When cells are active, they need glucose. And how active they are determines how much glucose they need. So if a cell is, let's say, very active, firing a lot of action potentials, that's going to cause it to take up a whole lot of glucose. Now, if we were to infuse the patient with some radioactive glucose, cells would take that up just fine. This has been modified, though, so they can't use it. So they pick up this useless form of glucose, and all it does is give us something to look for. So we can tell whether cells are alive and whether cells are active based on how much of this radioactive glucose they pick up. So we've got a couple of tumors here. One in the frontal lobes, one further back in the occipital lobes. Are they both alive? Are they both dead? It's hard to tell by just looking at an MRI, unless You pair that with FDG PET, and now we can see pretty clearly here that the tumor up front is a whole bunch of necrotic tissue. It's dead. We know it's dead because it's not picking up glucose. Any cell that's alive is going to pick up glucose. So it's only that occipital tumor that has remained. Now the diagnosis is also going to require a biopsy so you can determine what type of cell makes up this tumor. And that's going to be useful in determining whether it's a primary tumor or whether it's a metastatic tumor. Because a metastatic tumor, again, is always going to be more aggressive. It had to pull its way out of its original tumor, migrate into the brain, set up house there, and grow. Its ability to do that is indicative of a more aggressive tumor. The treatment, if you can, cut it out. So surgical excision is not always possible, but when it is, that's the best treatment. Get rid of it. For deeper structures, it becomes a risk-benefit analysis. Are you going to damage the healthy tissue to get to the tumor? Is it worth it? That surgical excision can also help relieve some of the intracranial pressure. So of course, if we're going to remove this mass lesion, we have to open up a hole in the skull, and that can allow us to relieve some of that pressure that's built up. When you take out the tumor, you can then do analysis to determine what type of cell is it. Now, we can also use corticosteroids to relieve that intracranial pressure. And here you can see the effect of a corticosteroid on the herniation that you get from this primary brain tumor. So on top, this is before. You can see the tumor's lighting up with the contrast agent. It's also herniating the brain tissue downward. Little corticosteroid treatment, swelling drops down, and we don't see that herniation. So corticosteroids can be very helpful in controlling changes in intracranial pressure and some of the problems that causes. Radiation therapy and chemotherapy are also useful for treating brain tumors. They certainly reduce the likelihood that a tumor recurs. They don't seem to improve survivability, although it does depend on tumor type. So these data here we have, on the top we're looking at recurrence. So in other words, progression at the initial site. What we're seeing is if we treat the tumor, does it come back at that site where we treated it? So in this case, moving upward is a bad thing. We want the lines to stay low. And what you can see here is that whether it's with radiosurgery or with just standard excision surgery, the addition of whole brain radiation therapy reduces that likelihood of recurrence. But on the bottom you can see that comparing whole brain radiation therapy to just observation, of course with both surgical interventions, there's no difference in the survivability. Although whole brain radiation therapy does seem to affect the regrowth of tumors, it doesn't actually help the person live longer. And that radiation can actually cause radiation necrosis, because the whole idea behind radiation therapy and chemotherapy is to kill the cancer cells. But we don't just target cancer cells. Other cells are going to be killed off with these forms of therapy. We target cancer cells more heavily, but that's not all we hit. And you can see here a few holes that have appeared in the brain following whole brain radiation therapy. And these can occur years afterward. So it can take some time for this to occur, but that radiation therapy can create its own problems. Spinal cord tumors are less common than brain tumors, and what's common here for them is pain. And the type of pain depends on the location. So when we're talking medullary, what we're talking about is it within the spinal cord tissue? Is it in the white matter and gray matter of the spinal cord? If so, that's intramedullary. Outside of that is going to be extramedullary. Now we can subdivide it a little bit further here, and we can see that most commonly what we have are extradural, or outside the dura, so of course those are extramedullary as well. So extradural tumors are going to be the most common, followed by intradural extramedullary. So most of the time you're going to see extramedullary tumors outside the actual spinal cord tissue. It's a rarer event to have it within the spinal cord itself. Now, even those that are forming in the dura or even outside the dura or within the bony tissue itself, those can press on the spinal cord and create different sensory motor deficits. So we're not going to impact cognition here, but we can certainly impact our ability to move by compressing the corticospinal tract. We can affect our ability to feel tactile sensation with the posterior columns, or pain and temperature with the spinothalamic tract. So in this picture, the corticospinal tract is shown in red, the posterior columns in blue, and the spinothalamic tract in green. And the body is colored to show you which of those is going to be affected. So if we have a destruction of the entire spinal cord, so just the entire area of it where we're getting our posterior column, spinothalamic tract, corticospinal tract, obviously everything is impaired at that level and below. Those hemicord lesions that can happen, so if you have a tumor on only one side of the spinal cord, there you can get asymmetry between the different sides of the body, where the contralateral side is going to have pain and temperature loss, ipsilateral would be motor and tactile sensation. Tumors that target the front of the cord are going to tend to affect your corticospinal tract and spinothalamic tract, and those that hit the posterior part of the cord are going to hit the posterior columns. So have a look through these different patterns here, and they should all make sense to you. Now the non-primary tumors are going to enter the central nervous system through the blood supply. And the most common sources are going to be the lung, breast, kidney, also GI tract. But you know, when you think about blood supply to the brain, this is one of the first organs that's going to be hit after the heart. So that oxygenated blood that's arriving from the lungs goes to the heart, gets pumped out, it's going to go up the aorta. There's a couple different ways to get there. It could be through carotid, or you can have the subclavian taking you to the vertebral arteries. Either way, the brain is well vascularized, and it's one of the first places to receive blood from the heart. And that's because the brain is so greedy. This thing uses a whole lot of energy. Even though it's about 2% of our body mass, it'll take about 20 to 25% of our oxygen and glucose. So all that blood supply is wonderful because it keeps it alive, but it also provides a route for entry for metastatic cancer cells. Now, because of how the carotid artery continues with the middle cerebral artery, so those are essentially the same thing. So your internal carotid is going to come up, and it's going to continue along to form your middle cerebral artery. They're essentially continuous. So most of the time you're going to find these metastatic tumors within the territory of the middle cerebral artery. Very rarely will you find it in the meninges. And when you do find a metastatic tumor, it's not uncommon to find another one. Because they're metastatic, they are able to actually wiggle their way through the blood-brain barrier and enter the brain tissue. Once brain tumors form, whether they're primary or secondary, what they're going to do is grow, increase pressure, compress tissue, and what that compression is going to do is affect the function of our nerves, our cerebrospinal flow, and blood flow. So just like last lecture, a lot of these diseases are going to have a lot in common. So whether you have inflammation, increasing pressure, or a mass lesion, a tumor growing, increasing pressure, same thing is going to happen. When you increase intracranial pressure, you run the risk of compressing those ventricles and their connecting aqueducts. So here we can see the ventricular system of the brain. So that blue stuff is all inside the brain. And there's an area of it called the cerebral aqueduct. that's going to run through the midbrain. This is a very small hole that's easy to compress, and when it gets compressed, like we're seeing here on the right, you get hydrocephalus, so you get a buildup of intracranial pressure. That intracranial pressure blocks CSF flow, and then your ventricles balloon up, putting further pressure on the brain tissue. Now, brain tumors are going to alter our blood flow in a couple of ways. So just like last time, that increase in intracranial pressure can block our blood flow. So if we build up enough pressure, what that's going to do is block the ability for blood to move throughout the brain, certainly around the area of the tumor. So that's just like last time. But what we have to keep in mind is that these tumors are growing. They're alive, and what they will do to help keep themselves alive is oftentimes stimulate the growth of new blood cells, new blood vessels. So angiogenesis, or the growth of new blood vessels, is one of the things that more aggressive tumors are going to do. So what they'll do is have the cells around them form new blood vessels, so they have nice access to blood supply. The more blood they get, the better they can grow. So by having better access to blood, they're going to grow at greater rates. But what they're also doing is really creating leaky blood vessels. They don't make a blood-brain barrier. So these new blood vessels here, so after the tumor stimulates angiogenesis, that creates the leaky blood vessels. And since we don't have a blood-brain barrier, it becomes easier for toxic substances from the blood to enter the brain. One of those substances is albumin. Now, albumin itself is not toxic to us. We eat it all the time. If you've ever had a fried egg, the white is largely albumin. So it's pretty tasty with a little salt, but it shouldn't be freely moving into the brain. And when it does, it appears to disrupt removal of potassium. Now, you're going to hear this a few times. So now's a good time to go ahead and get this in your head. If we increase the concentration of potassium outside the cell, alright, so here's our neuron here. If we increase the amount of potassium outside, what that does is stimulate the neuron. It causes it to depolarize. So that explains some of the seizure activity that we see in later stages of cancer. Now, normally, astrocytes buffer that potassium, just like in Lecture 1. When we have a leaky blood-brain barrier that's not working properly, albumin leaks in and prevents that potassium reuptake. And that's what we're seeing here in these data, believe it or not. So what they've done is simulate a breakage of the blood-brain barrier by just injecting albumin at the site shown in Part A. And you can see that that brain tissue is actually swollen up. So it should be a nice, smooth, curved top. But you'll notice at the site of injection with all the arrows, it's kind of bulging out. That's because of all the swelling that's occurred. In Part B, what they've done is stimulate in that little bar there. So we've got a couple of lines. And what they're measuring is external potassium. So with that first line, what they're doing is stimulating electrically, and when neurons are active, they start spitting out potassium and we get the buildup. When they stop stimulating, then there's a decay. Now that's normal. Whenever they inject with albumin though, you still get the buildup, but the decay is slowed, as you can see. So whenever we have our leaky blood-brain barrier, we have impaired potassium uptake. That's what those data are showing us in Part B, and what that leads to is epileptiform activity. That's what we see in Part C. So on the most left portion of Part C. That's just some electrical stimulation. You should get a very brief response and then nothing. And that's what you see in sham. Now with deoxycholic acid, that DOC, or albumin, ALB, you'll notice that there's this delayed stimulation. There's this delayed electrical activity. And that is indicative of epileptiform activity, so hyperactive neurons. And in Part E, they apply barium to show that it's because of inward rectifying potassium channels. It's really interesting if you care about that, and you probably don't. So don't sweat that. Do sweat this though. The inability to properly remove potassium after the blood-brain barrier is leaky is going to cause neurons to be hyperexcited. When neurons get hyperexcited, they die. Now the growth of these brain tumors can also just put pressure on nerves and neurons. So as the tumor grows, it's going to push on all the stuff that was running over here. Let's say we have a whole bunch of axons running by our tumor here. Well, we're going to put pressure on the axon, and when we put pressure on the axon, the first thing that's going to happen is demyelination. So when we apply that pressure, first the glia that were myelinating the axon die off. That's kind of their job. It's a fail-safe job. Really what they're there to do is to facilitate action potential propagation. But if there is some pressure here, they act as a cushion. So they die to kind of relieve the pressure, if you will. And that's what we're seeing here in these data. So the red color is showing you myelin, the green is showing you some potassium channels. On the left and in the center, we can see those. On the right, they're overlaid. Top, everything's fine. Bottom, they crushed the nerve. They put a little pressure on the nerve, and you'll notice there's far less red. That's the whole point. If you can see it, there's less red on the bottom. What you're seeing is demyelination as a result of pressure. And that's what happens in our heads as well. This is fine because glia aren't postmitotic, so they can make more themselves. It's possible for remyelination to occur. If we lose neurons, then we're screwed. That's what happens with prolonged pressure. Then we get neuron loss. This is problematic because, like you, neurons are special and irreplaceable. They're postmitotic, they don't make any more themselves, so when we lose them, they're gone. There's no regrowth like we have with glia. And when you have demyelination for prolonged periods of time, you see neuron loss. Believe it or not, that's what these data show. So A59 is just this virus that they use to cause demyelination. It's going to target and kill myelinating glia. And when you do that, when you infect with this virus and you count the number of neurons, you'll see lower. So look at control versus A59 in that bar graph, and you'll see fewer retinal ganglion cells. Those are neurons. So demyelination occurs with prolonged increases in pressure. Neurons are lost. Now, of course, just like last time, that increase in pressure can prevent the flow of blood, and when we don't have proper blood flow, neurons don't get glucose and they die. So that stuff is all still true. Now, the prognosis of different types of tumors, it's highly variable. The general principle here is that gliomas are going to be far worse than primary brain tumors that are not derived from glia. So comparing glioma to non-glioma, glioma's worse. That's usually the case, and you'll notice a difference in the prognosis whenever we go to the next slide. So these are organized here kind of based on their prevalence. The most common type of glioma is going to be the astrocytoma. And those can be high grade, meaning they're worse, or low grade. If you ever hear glioblastoma, that's just a grade 4 astrocytoma. And just like the name tells you, these are derived from astrocytes. Now, I want you to notice the prognosis on all of these is fairly poor. It's rare that you're going to live beyond 10 years. whenever you have a glioma, unless it's a neuroma. Neuromas are usually pretty good. Now, it sounds like it might be derived from a neuron, but we know that's not true. Neurons are postmitotic. A neuroma is derived from a Schwann cell. Because these are outside of the central nervous system, for the most part, so these are going to be myelinating, for example, cranial nerves. Acoustic neuromas are a great example here, so on the 8th cranial nerve. You don't have as much of a worry about dangerous increases in intracranial pressure. You know, you've moved outside the cranium at this point. So the prognosis is usually pretty good. And oftentimes, they don't do anything about it. Because again, age is the biggest risk factor here. So let's say you're 70 years old, and they tell you you've got, oh, I don't know, maybe about 20 years until you have to worry about this thing. By then you're 90. How well are you hearing anyway? But if we do the surgery now, you will definitely have damage to that nerve. You will have hearing loss. Right now. Not 20 years later. And so it's not uncommon to just wait and watch whenever you have neuromas. And that's because they grow very slowly, and they're going to be in a more ideal location, as opposed to astrocytes, which have to be in the cranium. Now the other myelinating glia, the oligodendrocytes, these also form tumors as well. These tend to be encapsulated pretty well, but they also tend to bleed, which is not great. So their prognosis is going to be worse than a neuroma. Ependymomas are derived from ependymal cells. Those are the glia that make cerebrospinal fluid. So the real risk here is whether they're going to grow enough to obstruct CSF flow. If they don't, the prognosis is usually pretty good, but it depends on the location. Oftentimes, those that are above the brainstem actually have a worse prognosis than those below. Now, the medulloblastomas, we presume, are derived from neuroprogenitor cells, but we're not sure yet. These are the least likely in adults, but they're a lot more common in children. And these are often going to affect the cerebellum. So ataxia is a common symptom here for medulloblastoma. And like the rest of the gliomas, except for neuromas, prognosis is not great. Prognosis gets a whole lot better whenever you look at the non-gliomas, except primary CNS lymphoma. But everything else is going to have excellent survival into 10 years, 20 years, so much better than our gliomas. Now the most common here is going to be the meningiomas. These form in the meninges. So you're going to see, of course, the same types of signs as with meningitis, for example, aside from the obvious signs of infection, but you'll have increases in intracranial pressure. The meningiomas tend not to infiltrate into the brain, but they usually will grow outward instead. And most of the time, you're going to these will remain grade 1, fairly benign. They can infiltrate into other tissues, but they won't move into the brain. Here we can see that they're kind of bulging out of the skull as a result of an infiltrating meningioma there. But survival, much better than your gliomas. The next two are going to affect the pituitary cells, either in development for the craniopharyngiomas or afterward for the pituitary adenoma. Now, the pituitary gland is going to be surrounded by the cavernous sinus, which contains a few blood vessels, and it also contains cranial nerves, 3, 4, 5, and 6. 3, 4, and 6 control movements of our eyes, so it's not uncommon to see cranial nerve palsies. It's also not uncommon to see hormonal abnormalities. Now, despite being in a fairly tucked in location, you can't access these through the nose for removal. Now, the hormonal abnormalities really depends on what kind of cells we're targeting. So here in the anterior pituitary, we have cells called tropes. And we'll color them in. So these tropes here are the cells that are going to secrete hormones. So whether we see an increase or a decrease in hormonal release depends on which cells have become cancerous. If our tropes grow much larger and there's additional cells here, they're going to release higher levels of hormones. On the other hand, if the surrounding cells grow up, compress, and kill the tropes, what we'll see is a decrease in hormonal release. So both are an option, but hormonal abnormalities are going to occur whenever you have cancerous growth in the pituitary, because the job of the pituitary is to spit out hormones. You also can see visual signs because of compression of the cranial nerves running alongside the pituitary. The next type of tumor would be the epidermoid and dermoid tumors. These are derived from ectodermal precursor cells. So this occurs early in development, before we've really separated our nervous system from the skin. And so these cancer cells migrate in very early on during development, live there, and often still develop into epidermal or dermal cells. So you might see hair, sweat glands, sebaceous glands, things like that, forming within the brain. These are usually well encapsulated, and depending on the location, they can be removed, and the survival is excellent, as you can see. The hemangioblastomas that are derived from vascular endothelial cells still have great survival. They tend to be well vascularized, as you would imagine, because they're derived from vascular cells. Usually they occur in the cerebellum, so ataxia is a common symptom here. The last tumor on here is the primary CNS lymphoma. The idea here is that lymphocytes get transformed, potentially by viral infection, such as the Epstein-Barr virus. So your normal, happy lymphocytes here are not going to cross your blood-brain barrier to enter the brain. So let's get a BBB up there, blood-brain barrier. Here's our brain over here. They're not going to invade that tissue. Infection with some sort of virus is going to transform them into a cancerous lymphocyte that is able to cross the blood-brain barrier, enter the brain, and form tumors. Now, these tend to occur in kind of deep white matter structures that are around the ventricles, as we can see here. So on the left, we can see a couple of different tumors that are lighting up with contrast. After chemotherapy, you can see they're largely reduced. The herniation that occurred is lost. So chemotherapy and radiation therapy can help improve survival. You can go from about 1 year, which is about what you'd have with no therapy, to maybe 3 to 5 years. Whether or not surgery is helpful is controversial. Because of their location, because they're buried in the white matter there, it's a little more difficult to access. And so you may do more harm than good by removing it. So it's sort of a case-by-case basis.